得到我的声音吗？
可以听到。
谢谢。
洪医师可以用英文吗？
可以啊，不好意思，
好
我今天用中文准备的话，不知道可不可以，还是要用英文嘛？
看你啊，如果可以的话最好，我会建议用英文了。
哦，好，
因为我们的听众里面有一个外籍医师。
好，那我
谢谢你哦。
试着用英文，谢谢。Good morning, everyone. I'm Dr. Hong from Craniofacial Orthodontic Department. And today I'm sharing my research progress. The topic is deep learning for 3D image-based detection of patients with obstructive sleep apnea, and it is a pilot study. We know that the etiology of OSA has many aspects, including the age, if the patient has brain injury, and including the muscle tone and soft tissue around the airway, which means that if the patient have obesity. And all of those different factors might affect the risk of the OSA. So for this kind of questions have many variables, it is always a good choice to use machine learning or deep learning as a tool for us to make a prediction or make the decision. And for our clinical practice, the most familiar part for us would be the structural features that give rise to the narrow airway, which means in our daily practice, we always use the lateral cephalometric X-ray, and sometimes you might use the head and neck CBCT, combined CT, and those images will give us a very good information regarding to the structural features. And those structural features might related to the OSA risk or the OSA etiology. So this is why we want to use the deep learning or machine learning combined with those kind of X-ray to predict the risk of OSA for the patients. And I reviewed the literatures among the past 5 years. And actually, a lot of different studies use machine learning or deep learning to try to build a prediction model and help us to differentiate if these patients have high risk or low risk of OSA before the start of the treatment. And those different literatures, some use the pronunciation of the patients to predict the risk of the OSA. And some use the at-home oximetry and airflow recordings, and some use different questionnaires. We know that a lot of different questionnaires, including Berlin and Pittsburgh Sleep Quality Index and April Sleeping Scale, those kind of questionnaire, each one will have maybe tens of 20, 30 different questions. And those big data is suitable for us to build a model using these different kinds of data. And some literatures use a waist circumference, neck circumference, BMI, to detect the OSA, and some might use myelopathy and hypertension. And we can even use the image of ECG and to use ECG image as an input to the machine learning or deep learning model. And they might also tell us if this patient have a high risk. And most important of all is the polysomnography. Sleeping tests also provide a lot of different data, and it is very suitable for us to incorporate all of these data to build a prediction model. And like I just mentioned, in our daily practice, we use lateral cephalogram and as well as the head and neck CBCT. And actually, a lot of different previous literatures use this kind of image and try to measure the hard tissue features. Some might use thyromental distance, thyrosternum distance, and the maximum interincisal distance to see if this patient had high risk of OSA. And some might use the different measurement, angular or linear measurement in lateral cephalometry X-ray to see if the patient had a high risk of OSA. And nowadays, we are more interested in the 3D image. So in this research, we try to apply the CT image measurements to see if the patient have a high risk. And this slide shows in the past, we use a lot of different measurements in the lateral cephalograms to use as input data for the machine learning. Soft tissue include the upper airway or lower airway diameters measured from the lateral ceph. And hard tissue, the most important measurement would be SNA, SNB, and ANB angle, because the ANB angle would tell us if the patients have a prognathic mandible or retrognathic mandible, and SNA, SNB tell us if the maxilla and the mandible, the relationship between the skeletal structure. However, in the meta-analysis, we already know that in those important landmarks we use, including SNA, SNB, ANB, they might infected by the cranial-based morphology. That means in different skeletal classification, class 1, class 2, and class 3 patients, the reference point as sella and nations might significantly different with each other. So this meta-analysis tells us that actually in the skeletal class 3 malocclusion patients, they tend to have a cranial base with a more acute cranial base angle and shorter cranial base length. And on the other hand, in skeletal class 2 patients, we can see that they have a larger cranial base angle and larger cranial base length. So because the significant difference in those reference point and reference line, that might affect the or cause bias when we try to find a relationship between the skeletal relationship and the risk of OSA. So how can we overcome this problem? That this problem is, the big problem is our reference might have some bias. So some doctor just use the whole picture, use the whole lateral cephalogram as the input to feed the computer and let the computer to find those important features in the whole lateral cephalogram. So that might help us to overcome the reference point, reference line bias problem. And in this study, actually, this is the only one study using the X-ray image as the input and combined with machine learning to detect if the patient had high risk of OSA. This is only one paper I reviewed. And in this paper, actually, he used a 2D lateral cephalogram as the input and combined a deep convolutional neural network. The network included 5 different blocks, and in each blocks, we resize the whole pixels of the lateral cephalograms. And after 5 blocks, each blocks, we will extract different features in the image. And in the end, we just flatten the network and connect it with a fully feed-forward neural network and result in a binary outcome to tell us if these patients have high risk of OSA or is low risk of OSA. And the result of this paper, actually, this paper come out with a binary outcome. The one outcome is patient with the low risk of OSA. That means the patient have AHI less than 5. And another group of patient is the patient with AHI more than 30. And this paper further divided into 4 groups. The 4 different groups use different input data. Group A used a full lateral ceph image as input data. Group B used the main region, they cut out the cranial vault and use the main region as input data. And Group C used only a head part as the input data. And Group D used the manual measurement as input data. And we can see in the middle part, the AUC diagram. The AUC diagram shows the goodness of the model. And for the manual analysis, we can see AUC, which is we can focus on the area under this line. And with a bigger area under the line shows have a better result. And manual analysis, the AUC may only have 0.75. And that means when we use the manual measurements, the computer can only give like a moderate result regarding to the prediction of the OSA. And if we don't use the manual analysis, we just give the computer the raw data, the raw lateral ceph image, we can increase the AUC to like 0.8. Nearly 0.9. That means very good result. So this paper tells us that maybe because the reference problem, just like I mentioned in previous slide, the cranial-based morphology. So when we apply the lateral ceph measurement, SNA, SNB, and ANB, we cannot detect the OSA very well. And once we use the whole lateral ceph X-ray as the input data, we can greatly increase the sensitivity and specificity of this model. And another thing we can know from this study is that full image, when we give the full image to the computer, it is better than we only give main region to the computer. Although the AUC is only 0.89 and main region is 0.92, but comparing the specificity and the sensitivity, if we give the computer full image as input, we can get a higher specificity and sensitivity, almost to 0.9. And so another thing is that we only use 2D X-ray, we can get a very high sensitivity and specificity. What about if we use 3D image? That's why we consider maybe we can apply a combined CT image as the input to get a more accurate result. And one thing is that the limitation of this study is that it divided the patient group into no OSA and severe OSA. That means the 2 groups in this study, one is AHI less than 5, and another group is AHI more than 30. Why they use this kind of classification? In this paper, the author, he actually say that because using this 2D image, they cannot find a proper feature detecting moderate to severe OSA. That means for patients have AHI from 5 to 30, this region of AHI, computer cannot find a very good feature in this kind of image. So they can only divide the patient with AHI less than 5, and another group is AHI more than 30. So when I further review the paper using 3D image as the input data, actually I found 0 paper using head and neck combined CT or any 3D image as input for constructing a risk assessing model for OSA. So here is our research proposal, is that we're trying to gather the CBCT image totally 1,500 subjects. And those subjects we want to use a normal BMI because we want to exclude the patient OSA caused by maybe too fat. So we won't try to include the patient with normal BMI and no previous OSA treatment, age more than 20. And male patients is because I review a lot of different papers. They only use male patients because actually male patient has a higher risk of OSA. And then we further divide the patient into the normal patients, that is the AHI less than 5, and mild to moderate patient with AHI 5 to 30, and severe OSA patient with AHI more than 30. And each group have 500 subjects. And within each group, we further divide all the subject into the training set and testing sets. Training set include 550, that 90% of the patient goes into the training set, and 10% of a patient, which is 50 subjects, go into the testing set. And using the deep learning neural network, we can use this input CBCT data and classify the patient into 3 different groups. That is the low risk group, which is the patient in the HI less than 5. And moderate group is the HI 5 to 30, and high risk group is HI more than 30. And by this kind of risk level assessment, we can know only look into the comorbidity of the patient, and we can know the risk of the patient have OSA symptoms. So right before the treatment, we can, in our orthodontic treatment, we can try to prevent tooth extraction and retraction of the tooth to increase the risk for high risk level patients. And even we can do this kind of risk level assessment before our OGS surgical simulations to give us some more information regarding how we move the maxilla and mandible. And there are a lot of different kind of neural network. The most traditional one is CNN, and we also have a lot of like package. For example, AlexNet, ResNet, and the most popular one nowadays, Transformer, is created by Google, and use this different kind of classification. We can try and error and to find the best model for the risk assessment for OSA. And we are now just trying to gather all the image, all the samples. This is for my today's presentation. Please give me some comment. Thank you.
Thank you, Dr. Hong, for the introduction of your study. And I think this is a good presentation, and also that initiate our interest and study in this kind of deep learning study. Does anybody have common question to this topic? May I invite Dr. Okay.
Sorry,
Dr. Zhou.
Hello. Yes. Hello, Dr. Hong.
Hi.
Sorry, I have one question for you. As I know, you focus on AI in the cephalometry and whole marking system, right?
Yes.
So in currently the software modality in our lab in B2, do you think that all the equipment is enough for your this kind of project to help you or assist in the project to do such kind of project? I'm wondering your questions. Yes. or
Okay.
you have to buy or purchase some yourself the own modality or other software to help you. Thank you.
Thank you, Dr. Zhou. Actually, now there are two difficulties for us in conducting this kind of research. One is the sample number. We try to get as large sample as possible, because this kind of image study we usually need like hundreds of samples for computer to really find good features for detection of the OSA syndrome. And another part is, just like you mentioned, we need a very powerful computer. As you can see, the study in 2021, I just presented, he used only 2D image and get the result, not very ideal result, because he can only divide into normal and severe OSA. They cannot classify accurately the mild to moderate OSA. And they use the image with 2Ds. And for 3D image, we need the image data is like more than maybe 100 times than 2D image. So we really need maybe a supercomputer. So actually, I'm in the lab in NTU image lab. So we can never use something like laptop to make the computation for this kind of data. And I know some doctors, some facility, they will rent like national level computer, 国网, to deal with this kind of the data. So I think maybe in our hospital, I haven't contacted the AI center. I know we have an AI center, but they ask for funds to, we cannot use it freely. So now by now I cooperate with a professor in NTU, in the information department. So yeah, that is
okay.
My answer. Thank you.
Thank you. Actually, I have two comments, because we have one colleague to do the AI, but he could not to design the AI program. He can cooperate with the other company, but he has to pay 厂商. So he could do the AI system to complete his project, and they could publish some very high levels the literature as well. So all this your project is be done in NTU, right? So
yes.
Yeah, there's a very good resource. Okay, thank you very much.
Thank you.
Well, I don't know the computer hardware. Is it really necessary to have a very high-end computer hardware to to do this kind of study? And that means that it could cost a lot of money to get a computer, the high-end computer. Regarding the sample size, it's always our limitation to do the AI study, because in our setting, the image number is always limited. For example, you estimate that you could get CBCT data of 1500. To those guys, computer guys, they still consider this is a small sample size. So, but I believe that we could find out some method that could use a so-called smaller sample size to also to conduct this kind of study. Dr. Lin Xiuxiao Boss, could you do you have any comment on this topic?
I have. 有听到我声音吗? Can you hear me? I have two questions. One question is about the region of ROI selection. Because previous study used a 2D X-ray to do a 4 kind of ROI selection. I want to know how do you choose the ROI region in for a city combined city. Second question is your object is to attach the AUC to 0.8 to 0.9 and divide your patient into 3 categories according to the AHI diagnosis. How to do this division into 3 classes. Thank you. And I have a third problem. Sorry. The third problem is for the deep learning. The big problem is overfitting. Overfitting is it means the accuracy is good for your training data, but not good for your testing data. Can use data augmentation apply to your data set because your data set only 300 samples. Thank you.
Thank you, Dr. Lin. The first question is about the ROI. ROI is we're trying to use a 3D image, so our ROI is the 3D a 3D patch image. That means that we will cut the 3D image in different patch, like a block, and to fit into the computer. And actually, we have some preformed architectures like 3D UNet or the 3D ResNet. This kind of the architecture, we only fit in the CBCT image data, and it will further rescale or resize the image for us to do the further computation. And the second one regarding to the AUC for 3 different classification, I'm not sure if you mean that how we can classify the image into 3 different groups. I think it's the same as the binary group. We divide it into 3 groups. We only feed the data into the deep neural network, and let for the binary classification, maybe in the last layer you will use a softmax, and for the three group classification in the last layer, it will maybe the last layer will be 3 different nodes and with different activation functions. And it will tell us whether the data will fit in the group 1 or group 2 or group 3. And in the 2D study, the AUC tell us that actually 2D image can get a pretty good result. So that gives us confidence that once we apply a 3D image, there's no reason we will have like a worse result comparing to 2D image. So that's why we try to incorporate 3D image. And the third question is regarding the overfitting. Actually, we will use a chi-square test to see if the feature really have an impact to the result of our risk assessment. That means if the certain features cannot pass the chi-square test, we will abandon these features. And But to be honest, it is really a try and error process because with so many different kind of architecture, we never know if this architecture is better, and we don't know why this certain kind of architecture is better using for the OSA detection. So a big part is only try and error.
Thank you.
Thank you.
Okay. Thank you. Could I invite Professor Yao Yifang? Could you make some comment?
Okay. First, I want to ask why do you say the normal BMI is an inclusion criteria?
Oh, okay. That is because I want to really focus on the skeletal structure. So actually, regarding to the computational power, we actually the first step is we will segment the bone out of the CBCT image, and we will use the 0 and 1 to represent if this pixel is bone or this pixel is not bone. And we use this kind of the image, this kind of data to further to try to compute if this patient has high risk of OSA. So we want to make sure that this patient have OSA is not because obesity, it's because of structural problem. So that's why we try to incorporate BMI with a normal value.
So your CT image will include hard tissue only, no
Yes,
soft tissue.
Yeah,
那
yes.
你会删掉很多，
对，其实
你会少很多 OSA 的病人。
哦，我其实有想到说，可能那个数量会不够啊，所以其实一开始也是会先尽量全部收集。如果有办法拿到足够的数量，才会都用 BMI 生产。
大部分的 OSA 病人都会有肥胖，觉得这样会少很多病人，就只有特定的病人有而已。
了解。
And I just wonder if you can conduct another study to use the 2D or 3D photo as a prediction material. It might be more helpful in clinic.
Oh, you mean use 2D image for
2D photo or 3D photo?
Oh, yeah. I think 2D photo is also a very good image because it will show the obesity of the patient.
2D photo, 3D photo, even can save the money, I think.
Oh,
if
okay.
you can have this kind of prediction.
Okay. Thank you.
Okay, Dr. Lin Zhenghui.
I'm more interested in the previous study. You cited the paper, the previous paper. They used cephalometry, and 可以再回到那张 slide 吗？就是它
这个
在更之前，对，这张 ，because they compare 底下那一张
，OK，
对。They compare the manual analysis. So how they do to do the manual analysis? What do they mean?
Oh, they mean they have a full group of input data, and for manual analysis is the input data include the measurement like SNA, SNB, ANB angle, or the distance between hyoid bone and mandible, and those scalar will used as the input.
Okay,
that means manual analysis. Yes.
So only linear and angulation measurements, right?
Yes.
So usually if we look at the pharyngeal airway, basically if you measure measure the volume or measure the cross-section area or measure the airway size. It's more directly related to the sleep study outcome. And usually, if we only use the linear or angulation measurement, the presentation will not show you the contribution of soft tissue and the airway dimension. That's why the manual analysis is less effective than the full image and main region. And so from the previous study, I would suspect that if you look at only the skeletal frame, the accuracy may not as good as this 2D cephalometry evaluation. So I would recommend you to use the include the pharyngeal airway, or you can the first stage you can try to include the pharyngeal airway first.
Okay.
And then you can expand. If you worry about the power of the computer, you can extract the SDL file and of the pharyngeal airway, and then do some study first, and then you expand to skeletal parts.
Okay, thank you, Professor.
就是如果是从呼吸道来想的话，其实呼吸道的体积这些东西，因为之前也很多 study 都是有在做这方面。那其实 cephalometry， 因为我们临床上面看到很多，就算是它 skeletal frame 很小，但是它还是有可能它的睡觉出来还是一样，还是 PSG 还是正常的，或者是说它的看起来 skeletal frame 是正常的，但是它 PSG 出来是很严重的，这个是都有可能，即使他们都是非肥胖的病人。
了解。
所以
再加入这一方面。
所以如果单纯看 skeletal， 大概很难吧，我是这样觉得。你可以做看这样子。
好，那你是想请问一下，就是 pharyngeal airway 这一部分，因为之前也有被一些老师 question 说，那个跟头部 head position 在 TAC-CBCT 的时候会有很大的关联性，所以也是有听到一些建议是说要先就是 standardize。
刚刚他在讲话，
照 CT 的
为什么这是红色的？
的确
是他是用嘴，
的确是会有这方面的 question。但是呢，其实如果要看 airway 来讲的话呢 ，airway 跟那个呼吸的功能应该是最相关的。
了解。
当然，要不然你就是要两个东西都加入了，就是说 skeletal 的 factor 跟 pharyngeal airway 的 factor 你都加进去。
我以为他
了解，
但是它会影响到你那个跑的速度啊。
对，所以可能也是会有点像是这篇 paper 一样，就是用不同的层次啦，可能就是 bone 的部分，然后再渐渐加到 soft tissue， 然后或者是看 pharyngeal airway 的体积等等，一层一层加上去，看它的精准度会不会提升这样子。
因为第一个就是说那个你要找1500个，这个大概，那有没有想过1500个是多少个正常的，多少个 OSA 的？
其实我规划是希望500个是正常的，可能还不是大问题。那主要就是会希望有1000个 case 是有 OSA 的，然后这1000个 case 可以再把它分成mild to moderate 跟一个 severe 两个 group。这样下去，因
为我反而觉得正常的会是比较难找的。 你要找到正常的，有做过 PSG 正常的，又有做 CBCT， 那他来做这个 CBCT 的目的是做矫正吗？还是做其他的事情？
我是构想是说正常的，就是直接我们临床上直接可能透过问诊，没有怀疑他有 OSA 就把它当正常。
那这些可能会 confounding factor 就非常多，因为你没有确定那个睡眠检查是 OK 的。
了解。
Okay, I do have a comment and question to Dr. Hong. I'm not sure if my comment is correct, so hopefully Dr. Lin, Dr. Liao could correct me if I'm wrong. The comment is that we could always easily suspect the patient have OSA by its clinical picture, like patient's facial type, symptom signs, or simply questionnaire. Okay, now your study is using image, either 2D or 3D, and also this is a static test, not dynamic test, and it predicts the risk. And then you still have to go to the final definitive diagnosis, which is PSG test. So Dr. Hong, you need to convince me that your study could contribute to either clinical final diagnosis or treatment result by doing a lot of this kind of spend a lot of efforts and tests and then find out that you could predict the OSA and then still go to PSG. Do you understand my point?
Yes, and I to be honest, I don't think this kind of prediction can be diagnosis, and it is not enough. But I think for one thing, for the orthodontic treatment, because it is still an open debate for high-risk OSA patients, is it proper for us to give tooth extraction treatment plan? Because some might wonder that if retraction of the teeth can cause the OSA to be more severe. So I think through this kind of screening for the patient with low or moderate risk of OSA, maybe it is a reason for us to give tooth extraction or retraction of anterior teeth as the proper treatment plan. And I think it is only a reference for us. And another thing is, I think a lot of AI tool is for the some region with not enough specialists, because in our hospital we have a lot of sleep specialists, so we can easily detect if this kind of patient have high risk. But in maybe some countryside, they don't have enough specialists. So use this kind of very easily screening tools can let the doctors, the local doctors, to have a very clear guide whether this patient should be referred to the center for further treatment. I think this is the maybe so far the two reasons I think the benefit of this kind of study.
Thank you for your presentation.
Thank you.
Is there any other question or comment? If not, I thank you, Dr. Hong, for your presentation again. I hope you quickly finish your degree and then come back to help us to establish this kind of research.
Thank you, Dr. Law. Thank you.
Okay, thank you, everyone. This concludes our meeting this week. Thank you.